was really excellent. And I have to say I'm very, very, very impressed. Yeah, there's your hemoglobin electrophoresis. So, the anemia was due to a hemoglobin S defect. And I just wanted to talk a little bit about sickle cell disease. It is an inherited disease. The hallmarks are the vaso-occlusive crisis and hemolytic anemia, which we saw in this patient. The belly pain or the left upper quadrant pain was actually due to, as we saw, ischemia of the spleen. But the most common reason why we see these patients in the ED is the pain from the vaso-occlusive crisis. For us, it's not always splenic. Usually it's like in the extremities, and that is the most common place for them to be having pain. Also back and chest and stuff like that. So yeah, we saw those lists, and if you're anything like me, when you see a bunch of, like, this is a shortened list for splenomegaly. And whenever you see a lot of things, that's kind of how I feel like George Clooney at the bottom there. And then I tried to make it a little bit more generalized. So you can think of it this way, and we see splenic engorgement from thrombosis being the second thing up there. But as you can see, it's basically like what makes it large and painful. But even a list like that makes me kind of freak out. So what I do instead is kind of let the differential guide my testing. And really I put into big boxes: infection, I don't know how to do all your things, infection, malignancy, and hemoglobinopathies. So these are the easiest tests you can run, the CPC, in order to find out whether they're anemic or whether this is something like a malignancy, which will show up with a bunch of white blood cells, or maybe pancytopenia. You get your reticulocyte count to see if the bone marrow is responding appropriately, or if this is something that, some myelosuppression. You get a metabolic panel with LFTs, because as Tess pointed out, the spleen and the liver are pretty intimately linked. As far as the portal vein is concerned, the splenic vein is the one that most, I guess, dominates or kind of contributes to the hepatic or the portal vein. And then peripheral smears in order to see cell quality. And sometimes you can, some people may have splenomegaly for something like malaria. You can catch pathogens just by the peripheral smear. In a young guy, especially in our population, you can never discount acute infection, especially with HIV. And then hemoglobin electrophoresis, you should always think of whenever you have Afro-Caribbean or African, people of African descent with splenomegaly and unexplained hemolytic anemia. Imaging, of course, and something that sometimes tends to be forgotten would be the monospot, because that can cause very painful splenomegaly as well. Oh boy. So I guess I'll talk about the management, because I don't know where I didn't have my management slide. So basically, management for these patients, if you see them for pain, Rosen's, if you look at the chapter on hemoglobinopathies, actually has a very nice kind of procedural way of giving them pain medication. I don't remember it off the top of my head. And then the other thing that you should do is make sure that you send them to a hematologist, because you're not going to be giving them any kind of medication that causes cell suppression, or excuse me, suppression of the hemoglobin that they have. You should leave that up to hematology. Generally, you're going to be giving them pain medications. If they come in very, very anemic, you should be giving them transfusion, but always remember that they need special tests. So make sure you fill out the form correctly, because there have been issues with that. Because they have extra antibodies. And that's pretty much it as far as the management is concerned from my part.